Good afternoon. I hope everybody had a good lunch. Uh, so, I'm going to talk on optical interventions. I'm going to focus a little bit more on which are actually working. Okay. So, this is, we all know, this is how we define myopia. And the prevalence of myopia at this point in school, that too in urban schools, is touching somewhere around 22.9%. And of these, high myopes are likely to be 2.7%. And it is estimated by this paper, which I have quoted below, that it's going to touch around 49.8% by 2050. And high myopia is also going to increase that much in proportion. So we are looking at alarming numbers, an alarming number of children developing moderate to high myopia, requiring a huge amount of care in their 40s. So all the myopia interventions were probably designed with the idea of providing some way to retard the progression of myopia from moderate to severe and from mild to moderate. So now the various optical interventions which are available and have been tried. One is of course optimal correction of the glasses. There was at some point a small theory that under correction works, but there has been that theory has been debunked, and I think there is no role for over or under correction in myopia, in even in younger children. Now the second option which is available for us is peripheral defocus correcting lenses, or what we call as dissociated, which have an element of deep peripheral defocus built in. Bifocal spectacles as well as progressive addition spectacles have been used, and then of course there are contact lenses which we will go in detail one after. So the most probably the largest data available which has some successful outcomes has been both using dissociated, I always get stuck in this integrated multiple defocus integrated multiple segment, that is what is DIMS. And they provide a little bit of a peripheral defocus. So if you look at the, is there a pointer? So the principle of the glass is that centrally, if it is appropriately, if the glass is appropriate correction in place, this is where the central optical zone is focused at the retina. But the peripheral rays provide a little bit of, because of the curve of the retina like this, they are focused actually a little bit behind. And this is the driver for eye elongation, because eye tries to elongate to get all the rays in focus. So if we can produce a defocus zone which will in fact make these peripheral rays instead of hyperopic, which will happen with a single vision lens, then this elongation of the eye mid peripheral. So there is enough evidence to show that mid peripheral retina and this hyperopic defocus is what drives the elongation of the eye. So if you can produce a myopic defocus of these peripheral rays, you can prevent or slow down the progression. So this is what both DIMS and HALT technologies are intends to do. They provide a ring of peripheral defocus, which provides a little, and they are slightly in HALT technology. It is really a ring of lenslets which are producing a ring of highly aspheric lens segments, and in DIMS it is lenslets of around +3 which consist of this peripheral zone. So if you look at the design of HALT or this, there is a central optical zone and there is a peripheral zone of defocus, 9 millimeter in case of DIMS, and I think 10 to 12 millimeters in case of HALT. So this peripheral defocus is produced by different optical elements in two technologies, but the principle remains same, that you are going to produce a little bit of a myopic defocus in the periphery instead of hyperopic defocus, which will happen if you give a single vision glass. So again, how well is it working? The data is available more for myosmart or DIMS lenses, which shows a myopia progression retardation by 52%, and also axial length elongation retardation by 62% compared to single vision glasses. We have it available for both single vision as well as we have it for both 6-year data also corroborates compared to 1-year data. Now, this is the study which I was quoting. As you can see here, there was definitely a progression retardation, and those who are interested can look at this study, which is the landmark study. HALT, as I said earlier, used the same. They were also equally effective, 67% on an average, but rider was they had to be worn at least 12 hours a day. This is a study which comes up with the use of HALT lenses, and you can see here they are. How do they compare with each other? There is only one study available which came out looking DIMS HALT slightly better than DIMS, but not great difference. I have very little experience with HALT, but DIMS, which is a longer experience, we are having a little bit better data on that. Bifocal and multifocal contact lenses have been tried, and they probably work best in situations where there is a little bit of esotropia for near or disparity in the esophagus. But generally, compared to the other optical interventions, other special spectacles which I said, they did not offer that much of retardation, maybe 20 to 25, and in spectacles even less than that. Contact lenses a little bit more effective in children who had esophoria for near, but almost not effective for other children. Now, dual defocus contact lenses are also FDA approved. That's the only FDA approved multifocal lens for myopia management. It is daily disposable, and again, it has the same principle, creating a peripheral myopic defocus, and that has proved almost as effective. If you look at 55 to 60% reduction in the axial length elongation and refraction, then this compares well with other two spectacle lenses, but there is definitely not much difference as far as the myopia progression is concerned. Orthokeratology, which is reshaping or flattening of the cornea to reduce myopia, and overnight use of these lenses definitely not only eliminates the daytime spectacle wear, but also slows down the axial length elongation. And central corneal flattening, which is in the center, is also associated with a peripheral steepening, and that's what produces the defocus effect. It was an unintended effect that it also started working for myopia control, and reducing the back optic zone diameter increases the efficiency of these glasses more.
Dr. Sumita, we are running
yes,
short
sir.
of time,
Yes,
please.
sir. Yes, sir. Last slide, sir. So they are effective in younger children, in rapid progressors, in high myopes, but microbial keratitis, especially in our country, remains a concern. Thank you so much.
Thank you so much. I think we're running short of time. Only one thing I want to say, that these are working at the afferent arm, what you're talking optical devices, and the atropine is working on the efferent arm. So a lot of work needs to be done. It's a very challenging area.
They are all very expensive options at this point.
The cost is a big
and
factor.
Cost is a big factor.
Just wanted to ask one, at what age do you prescribe this DIMS or lenses?
Youngest child I think we have done is around 6 years.
6 to 12.
6 to 12 is what has been studied
till now.
Yes. But I think ATOM 3, which is looking at slightly younger children, probably has an arm with these.
It's a vast topic.